glaucoma. At least finally we have a glaucoma talk. And today we are distinguished enough to have some external speakers who are going to tell us the new, novel, modern way of making our trabeculectomies better, reducing complication rates, and basically improving our outcomes of surgery using this class approach. So I'm just going to quickly introduce the speaker so that we can start on time and proceed. And I'm hoping I'm audible. I think I am. So we are going to have a very distinguished speaker with us. He's called Professor Shlomo Melamed. He's a professor of ophthalmology at the Tel Aviv University Medical School, the director of the Sam Rothberg Glaucoma Center, that's at the Sheba Medical Center, and the incumbent of the Zuka Sussman Chair for Glaucoma Research at the Tel Aviv University. All of these institutions are in Israel. Just a brief look into where he has come from, and he did his fellowship in 1983 to 1985. Most of us were not born at that time. So he finished his fellowship at the Massachusetts Eye and Ear Infirmary, a teaching hospital of Harvard Medical School, and he continued to focus on glaucoma service until 1988. Now he is the founder and organizer of several international organizations which are dedicated to glaucoma advancement. For example, he was the founder of the International Glaucoma Symposium, which he has been the president for many years. And he was also the founder and chair of the World Glaucoma Projects Committee, an international education and outreach program in the developing world from 2009. He's also the chair of the third World Glaucoma Promotion from 2009 to 2016. And he has organized and participated in expeditions in places like Papua New Guinea, Micronesia, Bolivia, Togo, Benin in West Africa, Burkina Faso, India, Nigeria, and hopefully when COVID is over, he will come to Kenya and grace us with his knowledge and his presence. But without further ado, welcome, Prof. Shlomo, and I'll hand over the talk to you. And he's going to talk about the class approach. He'll tell us what that is and how exactly it's going to assist in making our glaucoma surgeries easier and with better outcomes. Welcome, Prof. Shlomo.
Thank you very much, Sheila. And really, it's a real pleasure to be with you all, although I cannot see most of you. Hopefully, in the very near future, we'll meet we look forward to it. I would like, not to spend too much time because time is of interest, and I would like to discuss with you today the relatively new, I think we deal with it more than 10 or 12 years now, but this is really a novel approach to glaucoma surgery. I think Sheila defined it as improving trabeculectomy, and she may be right in many, many aspects, as you will see very, very soon. So the procedure is called CLAS, and this is short for CO2 laser assisted deep sclerectomy. So the basic question that we have always is how to improve our glaucoma surgery. Efficiency over a long term is really needed, and we want to reduce the complications, especially those complications that come from the very invasive approaches, like trabeculectomy, like armed valve and Barvelt and the other tubes that we use, etc. So it must be less invasive, and we prefer the term blabless filtration because we do believe that the formation of the bleb, the filtering bleb, although it is really required for a successful trabeculectomy, sometimes it is associated with too many problems. So novel, less invasive glaucoma operations are here and probably here to stay for 10 years or more. We have the minimally invasive glaucoma surgeries. We have the GDDS, it's glaucoma drainage devices, like Ahmed valve and the Barvelt, etc. We have the non-penetrating deep sclerectomy, and this is very important because, as you will see, the class, the CO2 laser sclerectomy is in fact a variant of this kind of procedure, the NPDS. We have visocanalostomy, which was done in South Africa, but didn't catch too much. We have canaloplasty, and also we have this new approach that I would like to spend more time with you today about, and this is laser-assisted deep sclerectomy, or CLAS. Okay, first of all, the penetrating versus down-penetrating surgery. Intrabeculectomy, which is the penetrating or any totally invasive surgery, we reduce the IOP for long-term with a high possibility of complications because of this direct entry into the anterior chamber. You know, complications like hypotony are there, and I don't want to mention others. We don't have the time. Oh, okay.
I have an issue with the slides, so just 1 second.
Hello?
Ask now.
Okay. Do you see the slides?
Yes, we can see the
slides are visible.
Okay, that's fine. All right, thank you so much. So on the other side, the non-penetrating deep sclerectomy reduces the intraocular pressure for long term, but with lower possibility of complications. High demand of skill, this is the main issue for the non-penetrating surgeries that are being used by diamond knives. We'll talk about that. And there's a very long learning curve, and that is why it is not that much accepted. Especially in the US, I don't know of too many surgeons that are doing NPDS. But it is a safe and effective method. Hard to master and skill because you deal with Schlemm's canal, and it's very, very hard for the knife, any thin knife made of any kind of diamond, it's very, very hard to manipulate the knife around Schlemm's canal without hurting the trabecular meshwork and the juxtacanacular tissue below. Here's a structure. This is a three-dimensional scheme of Schlemm's canal and the trabecular meshwork. And you can see from the left-hand side where my arrow is, this is the inner side of the drainage system viewed from the anterior chamber. We have the uveal meshwork first, then we have the corneoscleral meshwork where we have the beams, and they're associated and covered with trabecular cells. They have the ability to move around, phagocytose particles, and clean the system. It's like a self-cleaning filter, and everybody wishes that we had the filter like that in our car, so we won't have to change it, you know, every 5,000 miles. And then we have the juxtacanacular tissue, which is doesn't have beams, and this is the area of the most resistance to flow, to aqueous flow, and the main reason for glaucoma. And then we have the inner wall of Schlemm's canal, and then the Schlemm's canal itself. The aqueous goes into the canal, and from the canal it goes through the collector channels, about 30, 32, throughout the circumference of the eye, into aqueous veins and out into the venous system. It's a very effective system indeed. Now, what about the CO2 laser? It has some anti-fibrotic effects. It reduces spinal epidural fibrosis, and it's being used by quite a few neurosurgeons. It is also applied in cosmetic facial resurfacing procedures, you know, for the repair of the skin. The wavelength is 10,000 600 and nanometers, and the main advantage of CO2 laser. We do with it the unroofing of Schlemm's canal with the percolation of aqueous without further damage to the underlying tissue, which is the trabecular meshwork. And this is what we need. We don't want to hurt the deeper tissues of the trabecular meshwork, just to unroof the canal, and that way release the pressure, as you will see very soon. So why class? Because in most glaucoma cases, Schlemm's canal is flattened with bulging, herniated trabecular meshwork into the space. Most knives, when used to enter the Schlemm's canal laterally from the scleral spur, are too large for this space, and entry is usually associated with collateral damage. And that is why it has not been adopted by many good and even excellent glaucoma surgeons. Here you see the use of the knife in order to form the exposure of Schlemm's canal by a lateral entry. The unroofing of Schlemm's canal, gradually shaving off the dry scleral layers by the CO2 laser, allows a very gentle entry into the canal and exposure of the lumen of Schlemm's canal. Self-limiting procedure means that upon achieving endpoint, we see the percolation of fluid, which absorbs the laser energy and limits further ablation. So it is very, very safe, because once you expose the lumen of the canal and you see the percolation of fluid, any further use of the CO2 laser will be absorbed by this fluid and will not hurt, will not cause any damage to deeper tissues. Also, there's a question whether the antifibrotic properties of the CO2 laser may reduce late failures. We do form a scleral lake in the region, which I'll show you in a minute. Here you see a development of the CO2 laser. You see very nicely, as you see, I'm pointing it out right now, you see the very large space created here by ablation of the sclera and creation of a big lake, which will absorb this fluid. And this is an OCT, an anterior segment OCT of an eye that has been operated with class. And you see also the formation of the thin layer there with the lake, and another one here. So again, why class? It is a simple, repeatable, and replicable procedure. The learning curve of surgery is much, much, much shorter. It is so easy. I mean, you don't need to be a very advanced surgeon in order to do it. Class preserves the common steps in filtration procedure and bypasses the most challenging step in the NPDS, as I've discussed, and this is the manual handling of Schlemm's canal. We have, one of the main things here is the beam manipulating unit, which is added to the microscope. It's coaxial, so the laser is in fact going through the microscope, so you have both of your hands free in order to perform your procedure. First, we do as we do for all trabeculectomies, we create a fairly large scleral flap. And then, and this is very, very important, we really have to find the exact location where to perform the unroofing of Schlemm's canal. You have here the clear zone of the cornea, you have the gray zone here, and you have the white zone. And this laser allows for a pre-designed configuration of the area that you want to bleach or you want to graze with the laser. You can use all kinds of sizes and all kinds of shapes in order to do so. For the formation of unroofing of the canal, this semi-circular formation seems to be the best, and we have a lot of experience with that. Please see here all the steps that are required, and this is really fairly simple for people that are doing trabeculectomies. First, we perform and we design or fashion, after opening the conjunctiva fornix base, we form the scleral flap, and then we when we are pleased with what we see, we use, first of all, we do grazing of the sclera below Schlemm's canal in order to form the lake. Then we move on in a semicircular fashion to start the ablation of the roof of Schlemm's canal. You see here those 2 or 3 or 4 window effects of Schlemm's canal itself in the first stage. And then when we move to the last stage, this is what you see. In fact, you open the Schlemm's canal all around, and you don't see it here, you'll see it in the video. There's a percolation of fluid coming out. And then what you do, you simply suture, you apply 2 sutures to the scleral flap and use 2 sutures for fornix-based closure of the conjunctiva. And this is practically the operation. During surgery, you do not, I repeat, you do not lose the anterior chamber. That's the beauty of this. It's a very, very non-invasive or much less invasive surgery. Here is the video of a case that we did quite a long time ago, I might add. First of all, you see, we create the slab bed, then we change the design of the laser, and we start working more anteriorly. And here you see, we start seeing the opening of Schlemm's canal. You see that here. You see the percolation of fluid coming out. But we are not satisfied with that. We want to create more exposure of the canal and even take away those small bridges that are here. So easy, because you have your 2 hands are free, and you use your foot to apply the laser, and this is what you do. Now here, for instance, you can continue to hit this region as much as you'd like, because it will not affect the deeper tissues. The trabecular meshwork lies inside there, but it's not affected. Only percolated fluid absorbs the laser. And you see how beautiful it is now. It is continuous all the way around from edge to edge. Schlemm's canal is exposed, and you see the fluid coming out. And if you see here, the chamber remains deep because the rate of flow is not very, very quick, like we see after trabeculectomy and in totally invasive surgery. See how nice, the percolation of fluid is. We like the pace, and then we simply, put back the flap and put 2 sutures here, and this is the end of the operation. I'm sorry. Can we move on to? Is repeated here. Thank you. No. The other side. Okay. So some tips for a successful class procedure. Positioning is everything. It's very, very crucial and very important. Anatomical identification is very, very crucial. You should verify pattern positioning in the correct location, both for scleral lake formation and also the Schlemm's canals and roofing. So marking the limbus line is very, very important, but I think every surgeon can do it fairly easily. Wait at least 2 seconds between consecutive ablations. You have a better estimation of the last ablation effect, and also this enables percolated fluid to serve as the safety mechanism for the laser beam. Don't stop the canal exposure after first sign of percolation. We have a tendency to be so happy when we reach the canal. This is it. We are happy. We have to verify canal exposure and percolation from all the width of the flap, because it will add to us to the long-term success of the operation. Wide exposure area of the canal is necessary for effective IOP radiation for long-term. Here is a case, 1 month after class. You see the eye is very, very quiet indeed. The formation of the filtration, but in fact it's non-existent, it's fairly diffuse, okay? And yet the pressure in this specific case was 10 millimeters of mercury after surgery. We've done several studies right now, but I will focus here today on a very large scale study, an international study that we did in countries like Russia, Switzerland in 2 locations, Spain, Italy, India, and Israel, of course. And these were the results. First of all, the clinical results as far as safety goes. The safety profile of this procedure as expected, of course, because of it being non-invasive, it's very, very high. Early wound leak in, single digits percentage, shallow AC hardly seen, hyphema hardly seen, choroidal detachment hardly seen because there are no hypotony cases, etc. This is the main graph for the results of the operation. This is a classical graph of operative success after, for glaucoma surgery. First of all, you have a very, very deep decline of IOP early on, 1 day, 2 days, up to 1 week after surgery, and then it stabilizes, but remains throughout those 5 years, the 5 years follow-up, and right now we have more years of follow-up. You see that in general, all these pressures are excellent, even after 5 years. Pressure came down from 26 or so down to 14.3 millimeters of mercury. So this procedure can be used for the very advanced glaucoma, hard glaucoma cases as well, because of those good results. It is another way of looking at it by a percentage of IOP reduction. You see that after 5 years, we still maintain about 45% IOP reduction, and this is really a huge success. This is also another way of looking at it, because there's a breakdown here of people that were using medications. Per definition, we know that there's a complete success. We have IOP in the normal range, or expected normal range, without the use of medications, and we have qualified success. So despite the operation, yeah, the pressure came down effectively, but in order to keep it in a very successful phase, we need some medications. So you see here, a number of medications, 0, indicated in the blue, and you see that even after 5 years, about half of the patients still maintain their IOPs without any medication, which is another huge success. Also, if we look at pressures below 18, because sometimes the optic nerve is very, very compromised from glaucoma, the pressure, the target pressure that we aim for is certainly below 18, sometimes below 15 millimeters of mercury. And you will see that again, after 5 years, about half of the patients maintain their pressures below 18, which is again a very good indication for advanced glaucoma surgery. If we compare our results to historical results of trabeculectomy, the blue is the class and the trabeculectomy is in red, okay? You will see that in fact, this is a very similar operation, but the price to pay is much less because we have much less complications. So success rate is equal to a trabeculectomy, but the complication rate is much lower. And again, another way to look at the number of complications, you see many more complications in the invasive type of surgery like trabeculectomy as compared to the blue, which is class. And this is divided by early post-op complications, shallow chamber, for instance. Let's have a look at that. Only 5.6% in the shallow chamber versus 10% in the trabeculectomy. And this is a late post-op. We haven't seen a single case of endophthalmitis following class, but in trabeculectomy you can see it. Cataract development also, you see it in 80% of the cases. Also, not only acceleration of cataract is very well known as a side effect of trabeculectomy. You see it much less in class because of the non-invasive nature of this procedure. This is just to show you that worldwide, each and every center was unaware of the results of the other centers. And look, all these numbers are different centers from Mexico, Italy, Spain, Switzerland, India, Russia, Israel, etc. And you will see that the pattern is in fact practically similar to all centers. This indicates for sure that the procedure is working. Not only working, but it's working in the pattern of a very successful procedure, glaucoma procedure. There has been a very nice study looking at the retinal nerve fiber layer thickness change after class. I think this study was from Hungary, and one could see and that they reported that after 12 months, first of all, the best corrected visual acuity, but also the thickness of the RNFL didn't change, which means that indeed the pressure, the IOP that was reached through this surgery stabilized the damage to the optic nerve in those eyes. Also, you should know that class is, can be used and is used in combined surgery with phaco procedures, cataract surgery. And in fact, the steps are very, very similar. First of all, you create the flap of the conjunctiva and the sclera. Then you apply the mitomycin C, by the way, mitomycin C. And I think I have to really especially emphasize it here to this audience. I know I've been involved with a lot of surgery in African countries and also in the Black population in the West Indies, like St. Lucia, and also in the United States. And as you know, there's a tendency for the African population to scar down more than the Caucasian population following trabeculectomy. So I think that the use of mitomycin C is essential. And I think this increases the success rate in the African population or the African population as well. Should be done. Any case that we do class, anytime we use mitomycin C. In fact, we use it for any case of our trabeculectomy as well. It's very helpful for the long-term success of both procedures. Then we perform the phacoemulsification after washout of mitomycin C. We wash out the viscoelastic material and we perform the class as we do in all other combined cases. There are sometimes residues of viscomaterial that can adhere to the surgical site and block the percolation of the fluid. So what we need to do is use a Wexel, a sponge, and simply remove it and make sure that indeed it does not interfere with the procedure. Very easy. I will show you here a video. I hope I can show you a video of a combined phaco class with mitomycin C. Here it is. Okay. First of all, we fashion the conjunctival flap, fornix base. We cauterize the episcleral vessels and clean the conjunctiva. Then we create, in a second, yeah, okay, in just a second, you will see the formation of the flap. Sometimes we would like the flap to be as large as 5 millimeters, but sometimes you can do with 4 millimeters as well. And then using either a diamond knife or any other special crescent knife, we fashion the flap, and then we put mitomycin C, you could see here, wash it out, and in a minute, the operation will continue. I want, I think all of you are familiar with the steps of cataract surgery. And this is a clear-cut phacoemulsification of mid-sized cataract, then the implantation of the intraocular lens in the bag. And then after we finish doing that and bring the pupil down to its regular size, we come back to the flap and start doing, first of all, as you can see here, we did performed the scleral bed, and then more anteriorly opened the Schlemm's canal by unroofing it from above with the laser, and without losing the chamber. Right now, it's following cataract surgery, the new intraocular lens is in, and fairly easy. You would then close the flap with 2 sutures and then close the conjunctiva. And this is in fact the end of the combined operation class with cataract surgery. And the success rate, as you will see, is indeed very, very good. I think we can move forward. Yeah, okay. So why should we do combined phaco class and why is it a preferred solution? Well, you know, there's again the question of efficacy and safety combined. A very good best corrected visual acuity that we achieve following the cataract surgery itself. The efficacy is very similar to combined with TRAB, and both are higher compared to the MIGs. You know that we have a question of efficacy of all kinds of MIGs, and I don't want to spend too much time about that right now. The safety profile is higher compared to combined with TRAB, and it resembles the safety profile of MIGs, but without the use of MIGs. So this is a very, very large advantage. There is this study which was very, very interesting. It was performed in Peru, and they were, I don't know if I don't see that. Yeah, I hope you can see it, but they had a very, very a nice success rate at 1 year with pressures and with visual acuity. And they did a comparison with trabeculectomy and cataract. And you could see that, you know, in their series, the combined surgery of class with cataract surgery performed better. So, in conclusion, class or CO2 laser sclerectomy, more studies in most centers are underway. In fact, right now we know that you know the company is now owned by China. You know, a very large Chinese company, Canon, that operates the class operations in China. And we know that right now in China, many surgeons are using it, and a lot of patients have been exposed to class. Also, same goes for Singapore and other places in the Far East, which is interesting. Also in Europe, in other countries, it is very simple to perform. It is very effective in the reduction of intraocular pressure and the reduction of number of medications, especially in the in the very advanced cases. The safety profile is indeed very good, excellent. The potential hurdles to long-term success are the reattachment of the flap. Well, we don't see that much, to be honest. Well, there's a question that we raise sometimes. Does the CO2 laser really help in the issue of fibrosis? This is an issue that I bring up again, especially for the population in Africa. Maybe it does have an advantage, and I think this should be really tested. And also, this is not a question mark. I think this should be an exclamation mark there. There is certainly a role for antimetabolites like mitomycin C, especially in the African population. I'd like to thank you very much for listening, and I would be very, very happy to answer any question that may arise, you know, from the audience. Thank you so much.
Okay, thank you so much, Professor Shlomo, for that very informative talk. I must admit, in East Africa or in our region, we usually just do a complete full thickness sclerostomy using either the curly punch or, okay, we just do the traditional trabeculectomy. We don't do much of the deep sclerectomy. But in, I think most of the other centers, the deep sclerectomy, I think, is very popular, especially in Europe. And in those centers, the cases I've seen, they use collagen implants or some other non-absorbable sort of implants. And this help reduce the fibrosis of the sclera. I don't know, in this procedure, is there any role for the collagen implants, like in deep sclerectomy?
Thank you. Well, you know, it's very, very interesting. I think that you know Tarek Sharawi, who was my co-president of that meeting in Accra. In fact, Tarek was the first one to use the collagen implant in his NPDS early on, about 10 or 15 years ago. I'm not so sure that he's using it right now. Today, there are some better filling devices, if you will, or filling materials like Ologen, and some are using very, very viscous Helon, you know, hyaluronic acid, etc. This may be a good idea, especially when you do a very, very deep scleral lake, you know, more posteriorly, because it maintains the depth of the lake and provides more space for the percolation of fluid there. We have not, I repeat, we have not done any comparative study with and without Ologen, or with or without a device under the scleral flap. But I think it's interesting, and I know that some people use it, and they are very, very happy with it. I have to tell you honestly that even in my trabeculectomies, I don't use the Ologen because we have very, very high success rate. And I don't think we need it, but maybe it will be a good idea to use it in your patients, or at least to do a study comparing the with and without. Thank you.
Okay, so there's a couple of questions that have been raised about the first is a question from Dr. Gohil, and he's asking, can this laser be fitted to any microscope? And if possible, give a rough estimate of the cost. And the other question also that is related is, this is Dr. Masila, one of our glaucoma experts. Thank you for the presentation. What is the cost in terms of investment of the laser, and how long does the laser last? So maybe those are like two questions. Can it be, is it compatible? Is that device compatible with any of our operating microscopes? And also, what is the cost of the laser itself, of the unit?
Yeah, okay, thank you, Sheila. I have those questions in front of me, and I think it'll be better for me to give the opportunity to answer those questions to Aki, who knows it better. You know, I'm just the professional side. I'm the MD. I'm ignorant with all issues related to money and engineering. So please.
Okay, before we go to Aki, maybe one more question on the technical side in terms of the surgery. Back to the deep sclerectomy, we know that when the pressures are high, you can do a goniopuncture using YAG. Is this also a procedure we can do in this, for this, when we use the class? Can you also do the YAG goniopunctures? Yeah, and how effective is that?
Yeah, okay, this is very interesting. Thank you for this question. And, you know, if I recall it right, in our series, we needed to perform, I think, only 2 goniopunctures with the YAG laser so far, which is very, very interesting. Why? I think, you know, what was done by Dr. Andre Mermoud and Tarek and the Swiss surgeons early on with the NPDS, they really insisted with going with the knife into the cornea and creating a decimate flap together with the scleral flap. And then they thought that they would be able, if the pressure will rise, they will be able to go directly at the decimate flap and perform the goniopuncture there, all right? And in fact, this was very surprising because in one of the studies, I think that Andre Mermoud did, he, you know, it was required for him to perform YAG laser goniopuncture in 60% of his cases. And then they came down a little bit. We had a lot of discussions about that. I think, personally, I think that by the mere fact that we are unroofing the canal from above, we have a lot of advantages. I haven't discussed that with, you know, within the lecture. Why? You have to understand the structure of Schlemm's canal. In the canal itself, first of all, there are bulges of inner wall canal into the lumen of the canal, number one. And number two, there are septa. You know, the septum is one, septa, several septa. There are, these are structures like columns inside the canal that maintain the opening of the canal in normal pressures, okay? Now, if you come with the laser and you do grazing of the sclera, you come from above and you open the roof of the canal, inadvertently you tear down all these columns and you also graze some parts of the inner wall of Schlemm's canal, which may be an advantage because there's much more percolation and much more fluid coming out. And that is why we have a very effective procedure, you know, and we have some inadvertent good results to the fact that we are doing laser unroofing of the canal. And I think that this is why we have not seen, and by the way, we don't take care that much about the formation of the Testament's flap. We don't care about it because we think that by the mere fact that we perform the unroofing of the canal and doing all those shticks associated with it, this is enough for us. And the pressures that we see are good enough after this procedure. So having said that, I'm not surprised that we don't need to perform YAG laser goniopuncture in abundance. But maybe in some cases you do.
All right, and just as a follow-up, one of the attendees is asking,
yeah, I'm sorry?
Yeah, she's asking, is it correct that the inhibition of the drainage is always distal to the trabecular meshwork? I think basically what she's asking is that most of us are of the idea that, I mean, the common knowledge is that the increased resistance is at the level of the trabecular meshwork. So, and now you're going distal to the Schlemm's canal, and you've not really dealt with the resistance at the level of the trabecular meshwork. So are you going to get maximum reduction in pressures by going more distal to the trabecular meshwork? I think that's the question.
Yeah, I think I touched upon it a little bit, but I will, add some more information. First of all, when you open and you unroof Schlemm's canal, you have several advantages. First of all, as I said, you get rid of the 30% resistance to flow, which is posterior to Schlemm's canal or distal to Schlemm's canal, number one. Number two, as I explained, by the mere fact that you graze inside the lumen of Schlemm's canal, in many cases, first of all, you remove and you disturb the structure of the septa. And that is, by tearing them down, you create islands of openings in the inner wall of Schlemm's canal and the JCT. So in fact, it's a little bit more than just unroofing of the canal. You also interfere with the internal structure of the trabecular meshwork as well. Also, by the mere fact that you open the Schlemm's canal, you allow for a circumferential flow to be more active, coming in from the cut edges of the Schlemm's canal. Circumferential flow is very, very important in the flow of the canal. And once you do, we did some studies back then in Harvard in the nucleated human eyes about the importance of circumferential flow. I don't want to spend too much time on it. So the three things that are associated with the unroofing of the canal are getting rid of the external 30% of resistance to flow, damaging or impacting structures within the canal like the septa and the inner wall herniations, allowing for changes within the trabecular meshwork deep layers like the juxtacanalicular tissue and the inner wall of Schlemm's canal, and also an enhancement of the circumferential flow. That is why, it's a holistic kind of trabecular treatment, affecting Schlemm's canal and also the inner parts of the trabecular meshwork, but without tearing the trabecular meshwork altogether. So the anterior chamber is maintained deep, and this is what we like to see. Anyway, in very, very few cases, sometimes we can see iris coming out, in 1 or 2% of the cases. No problem there. We can convert to trabeculectomy if this happens. If sometimes the trabecular meshwork doesn't hold, But these are very, very few cases indeed. And you know, if you convert to trabeculectomy, it's not an issue as well. So I hope I answered this question regarding trabecular meshwork effect.
Yeah, I think that is very clear. Also, there is a question on how does, would it work in congenital glaucoma? Is this a procedure you have tried in children with congenital glaucoma?
Okay, thank you. It's a very interesting question. I'll have to disappoint you and the audience. We don't have any experience with class in congenital glaucoma. These are different kinds of patients, as you know. And there, it's not only a question of Schlemm's canal, also Schlemm's canal is maldeveloped. So we had a real question regarding any kind of efficacy trying to open the canal. Also, you know, it's very interesting, if the pressure is very, very high, like 80, excuse me, not 80, 40, 50, etc., there's a tendency for the canal to collapse. So sometimes, especially in those kids, we presume, we haven't done it, it would be very, very hard to expose exactly the roof of the canal. So we decided not to involve children with congenital glaucoma at this stage, and we don't think we shall do it in the very near future. However, for instance, patients with chronic angle closure glaucoma benefit from this procedure a lot, and you know that in China there are many, many patients with that kind of disease, and we know, and we right now have a lot of publications from Chinese surgeons, and they are very happy with the results with their congenital, with their chronic angle closure glaucoma cases. So not all of the cases will benefit from class, but I would say that 90% of the cases will benefit from class. Congenital glaucoma are not recommended. We don't have experience. Yeah. By the way, I don't know how many cases of pseudoexfoliation you have in Kenya?
In Kenya, we don't have much pseudoexfoliation as there is in Ethiopia. Ethiopia has quite a high number of pseudoexfoliation. Yeah. In Kenya, just in some parts of Kenya, the northeastern parts of Kenya, most of the, especially the community that comes from the Somali community, have a lot of pseudoexfoliation. Wow. But you know,
this is very interesting. You know, sometimes you can follow migrations of peoples around the globe. You know, according to the incidence and prevalence of pseudoexfoliation. Indeed, we see a lot of Ethiopians from with Jewish origin here in Israel, and we did studies in that population, and they have a lot of pseudoexfoliation, but we see it from others as well. And by the way, I just wanted to mention that the class is very efficient in cases with pseudoexfoliation glaucoma as well. So.
Okay. All right. Thank you so much. And
thank you. It was a pleasure. Thanks a lot.
All right. Now we're going to move on to the technical brief by the Optima representative, and his name is Aki Kushnir, and I guess he'll take us through the technical details of how to fit it onto our microscopes and the price and how much the whole unit is going to cost, and also can it be used in other kinds of ophthalmic surgeries apart from glaucoma? How versatile is this unit? Thank you. Aki, you can go ahead.
Okay, can you all hear me?
We can hear you, but there's quite some echoes.
Can you, okay, now is it better? Just to check that everything is working fine?
Yeah, sounds good. Go ahead.
Okay, perfect. So first of all, thank you so much for the opportunity to be here today. I'll just very briefly introduce myself. I'm video. Ah. Okay, now you can even see me, right? Okay, so I'll just briefly introduce myself. I'm the Director for Medical Applications and Technical Support at iOptima. And today, after the very interesting talk that we had with Professor Melamed, I would like to put some more focus on the class procedure, but from the technical side of view. So the technical aspects. I've already seen a very interesting question that was raised, and I will answer to that as we go along with this presentation. And also, what we're going to do today is we're going to look at the different components of the system, okay, how they interact with each other, and also the technology behind the CO2 laser. So understanding the technology and the advantages of the CO2 laser will enable you to understand really how is it so beneficial and safe and efficient to use. I also want to show you a very interesting case study that was done in China, again showing how it is possible to optimize the unique advantages of the technology during the surgery. At the end, we'll just talk a little bit about, if we already have a CO2 laser system, what other applications we can use it for. So first of all, that just came now, the question about how is the system any type of microscope. So that's a very good question, okay, because every OR will have a different manufacturer. The system, you can see here how it looks like. Basically, we have a laser, we have a control unit, we have a scanner, and what we are able to do is with a set of special adapters, we can actually fit. The scanner is the only part that has interface with the microscope. So we are able to fit with those adapters. We have a special adapters for Zeiss, for Leica, for Topcon, and so forth. So basically, we had a wide range of capabilities to fit to any type of microscope, thanks to that. And if we have a look at the components, so we have the CO2 laser that you can see on the right-hand side. Over here, this is the control unit, okay? This basically allows the surgeon to select the different shapes and patterns, and also to communicate with the scanner to allow us to use the patterns specifically for the needs of our surgery, of our class surgery. The scanner, you can see here, this is the component that connects to the microscope, and also it takes the input of the laser beam. Now, this is a very sophisticated system of galvamotors and optics. We'll talk a little bit about it, how it functions, but this basically allows us to have very accurate ablations of the sclera according to the pre-selected shape and size of the patterns that we just choose. So this is the scanner, the beam manipulator unit. What is important to understand here that we have some galvamotors and optics that, again, we can have an input here of the laser beam. The laser beam has a spot size that we cannot really use for the surgery. So this is where the scanner becomes very effective, because we can use that input, and the output would be a scan pattern that can ablate the tissue according to our specific needs. And this is where it connects to the microscope. Control unit, just spoke about it. Basically, it is the communication channel between the laser and the scanner, and your ability to manipulate and change. You can see down here that you can have different presets that are possible for you to use, but also you can use the different sizes manually. So it gives you a lot of freedom and flexibility to use the patterns and the sizes in real time according to what is in front of you. If we move along to the core of the system, which is basically the CO2 laser. The CO2 laser, well, you probably know it's well known in the medical world. It has been introduced firstly in the mid-60s. In the decades to come, it has become more and more apparent, more and more used in the medical world. It is one of the earliest gas-based lasers to be developed. We are very proud here in Israel to be part of the innovation that actually started the whole movement of laser to the medical world. And the reason why it is used so widely is because it has properties that allow us to create very precise incisions, and it is mainly known to be used as a cutting tool. It is applied, as I mentioned, in neurosurgery. In dermatology, there's a lot of use in CO2 laser. Plastic surgery, oral and maxillofacial, general surgery, and also we'll show you how it is used specifically in ophthalmology, in glaucoma surgery with the eye optimate system. What is also apparent is the fact that it can seal blood vessels less than 0.5 millimeters wide. And this is bleeding operatively is very much reduced. And also post-op edema and swelling and the healing process becomes much better when we use the CO2 laser. Let's try and understand why we have these characteristics of the CO2 laser. So first of all, it is very effectively ablating dry tissue. This is the main reason why it can be used as a cutting tool. So when we have dry tissue, the laser can really create precise cuts. It can really effectively ablate, evaporize a tissue, and give us this advantage. And you can already, from the presentation from Professor Melamed, you can understand how that could really suit us, because we need to remove sclera tissue that is considered to be dry tissue, and we want to have control. We want to have accuracy and precision. And the laser gives us that, thanks to the fact that dry tissue very effectively can be ablated. Now, if we go forward, the other aspect that is critical for us is the fact that it is highly absorbed by water. If you have a look here at this little table, it gives us different types of lasers. And on that left-hand side, you can see the absorption coefficient. So here you can see water. Basically, if we analyze how lasers are absorbing water, we can see that, for example, argon laser is not very effectively absorbed in water. If we look at CO2, we can see very high absorption rate. Now, this is critical for us because it means that whenever we will be able to unroof Schlemm's canal and reach aqueous humor, reach water environment, we are safe to ablate without actually causing any tissue underneath the water to be affected. And we use this great characteristic of the CO2 laser specifically for the class surgery. Again, if we're looking at the scanning capabilities, the fact that we're able to scan the laser beam very quickly into a scan pattern, this allowing us to very much limit and minimize any thermal damage to the tissue as a result of the ablation of the sclera. And this is again giving us here an advantage. This video really illustrates well how the CO2 laser behaves when we have a dry tissue. So this, imagine this paper is sclera. You can see very accurately, you can remove layer by layer. Usually we're talking about 30 microns every time we ablate. So it's predicted, it's known, we know what to expect, and we have control. Now, when we introduce water, look at what happens. Underneath the water, nothing actually is affected. So you can imagine that if you take that into the situation of the surgery, once we reach aqueous humor, the trabecular meshwork underneath will stay intact because this is exactly representing what we have underneath the water. Nothing really goes through. So this is again the safety mechanism, the self-regulatory mechanism that allows us to have a new flow of aqueous humor to reduce the pressure, but without penetration into the anterior. Okay, so this is just a short explanation how we use the laser together with the control unit and the scanner to give us the outcome that we want. So we know that the laser is a fantastic surgical tool, but the laser, the input, what we get from the laser is a spot size aiming beam that we cannot really use if we want to unroof Schlemm's canal or if we want to create a scleral lake. This is where the control unit and the scanner come handy, because we can manipulate that spot size aiming beam and create from it those little patterns. So we have a square patterns, a rectangular, and an arc. What happens in real time, this is not visible to the eye, is we have a very quick movement together with the optics and the galvomotors of the spot size aim laser beam that allows us to very rapidly create the patterns that we need for our specific steps of each of the surgery. If we're talking about a rectangular, I'm going to show you how we also use the square pattern, and of course the most important part, the arc pattern to unroof Schlemm's canal. So again, we combine the fact that we have a high efficacy of ablation of dry scleral tissue with the laser beam to create the scleral lake deep enough, later on to unroof Schlemm's canal. And when we actually reach the water content, the aqueous humor, we are going to be very safe because of the self-limited safety mechanism that we've just illustrated to you. This is what I just mentioned a minute ago. The laser beam is actually being scanned very quickly, and we avoid any thermal damage because of the fact that we are able to create the pattern very rapidly, faster than the thermal relaxation time. So we are actually avoiding any significant thermal damage as a result of that. Here is just an image to explain to you that the laser aiming beam is very important to come perpendicular to the tissue. This is how we create, every time we remove about 30 microns from the roof of Schlemm's canal until we reach aqueous humor, and we are not affecting the trabecular meshwork underneath. I want to show you here an interesting study, an interesting case from China. You know, I have, as part of my role, I have to visit and train different doctors in different regions. Every market, every country, you know, behaves a bit differently. In China, it's very interesting. We have a lot of activity there. In China, for example, of course, the anatomy of the eye is going to be different. Cases will be different, but in this case, I want to show you this specific surgeon from Qingdao Eye Hospital in China. They really, what is important to them, they're even pedantic about it, is to create a very deep scleral lake. Now, when I talk about the deepness, I'm talking about thickness in terms of the fact that we want to remove about 90% of the scleral tissue when we talk about creating the lake. So here you can see the 5x5 scleral flap. I will move it a little bit forward to show you how they are starting to work on the scleral lake. So here we go. So when the scleral tissue is dry, you can see the first ablations, the ablations will remove about 30 microns. Now they really want to reach a level of precision and accuracy that is very high. And to do that, what they are doing, they're actually going to use a sponge that will be soaked with water. So now it is not very much soaked. There is a little bit of water that gives them more control. So, for example, they want to reach even deeper, but without exposing any choroid, any ciliary body. To do that, you can have a look now. They will start and use a sponge which is really soaked with water content. And that allows them to have more control and to go deeper and deeper. Let's have a look. You see the sponge is soaked with water. So now, because there is water, a layer of water, the ablation is going to be with more control. They will remove scleral tissue with more control. And you can have a look to what level they reach after a number of ablations. Oops. Okay, you can really see the darker color. becoming visible, and they have a lot of control thanks to that. Okay, so this is the point where it's more or less enough for them, and I want to show you what happens when they move on to, they use the square pattern on specific spots. Again, move. Okay, moving to the arc pattern. Now, Professor Melamed has explained how important is the phase where you have to locate it in the right position. So you can see here the gray zone. You can see exactly where we have the transition phase. This is indicating where the Schlemm's canal is. So positioning the arc pattern exactly in the right manner is crucial, is critical. And you can see here, positioning is perfect, just between the right spots. And we start to ablate. Again, when the scleral tissue is dry, you have more layers, more deeper, you are reaching deeper in terms of unroofing Schlemm's canal. You can see here, this is a good sign that you are in the right spot and you can start to see percolation. And again, what Professor Melamed has mentioned is we don't want to stop now. First sign of percolation is not enough. We want to get, the endpoint is going to be reaching really nice natural flow, as you can see here. And this is giving us an indication, okay, this is going to probably tomorrow, the day after, 1 day pre-op, we're looking to have 6 to 10 IOP. And when the flow is visible like this, we know that we've reached the endpoint. Now, another addition feature that we are introducing is connecting the channel, the percolated area, with the scleral lake. So we can create a square, as I've mentioned, and the square will connect now the tunnel between the percolated area and the lake to have a better connection between them. So this is a very interesting way to show you how they're utilizing to the maximum the scleral lake to improve the pathway of the aqueous humor into an intrascleral pathway. And basically, to summarize everything, I think that the fact that you have very precise and very accurate ablations, the learning curve is short. So, you know, complications that are associated with NPDS require very technical skills. The fact that you have here something that is predictable, 30 microns of ablation each time, is really helpful to learn and master the technique very quickly. The CO2 laser technology, again, the fact that we can absorb, the energy is absorbed in water, gives you a self-regulated safety mechanism. The anti-fibrosis properties of the CO2 laser, we mentioned that, we can coagulate also blood vessels, and the simplicity to perform. The effective scleral lake to eliminate any bleb-related complications later on, and improve and generate alternative absorption pathways. Okay, and that will give us, in the end, non-penetrating procedure, less complications compared to trap, and also the long-term efficacy that we are looking for in terms of reduction of medication and IOP pressure. Lastly, I want to talk about some other applications that the laser system can have. This is interesting if you have in your clinic or in your hospital also, you know, ocuplasts that are using surgeries such as the eyelid surgery. So the whole unit has an advantage that you can actually utilize that, you know, for glaucoma patients, but at the same time, all you need to do is change the handpiece and it can be used for blepharoplasty, for eyelid surgery. Because of the same principles that we've mentioned, the precision as a cutting tool, the fact that we can coagulate blood vessels, that gives us, again, very high advantages when we're using it also for skin resurfacing in that instance. So very interesting it will be to also improve the fact that return on investment if you can also utilize the system, not just for glaucoma surgery. That's it for now. I'll be more than happy to answer any questions that you have.
Thank you so much, Aki, for your talk. That was very informative and encouraging to see that glaucoma, I never knew that glaucoma and oculoplasty will ever meet. And it's funny to see they have met, you've brought them together in this with this technology. I think somebody had asked the issue of cost. I don't know if that's to be answered by you or by the representative from Negas Med. So what would be the cost implications if somebody was to purchase this machine? And is the CO2 laser, is it, somebody had asked how long it lasts. I guess they were asking, is it something that would work indefinitely?
So maybe just before I hand over, I will just relate to the question about maintenance. So the laser is very robust. So from my experience, and I have experienced 4 years in the company, usually there is no real maintenance. There's a yearly maintenance, but basically it is something that is very robust. The only thing we have to take into account is change of laser source once every 4 years. So basically maintenance is very simple. We don't come across anything critical, you know, breakdown of parts or pieces. This is something that is very reliable from my personal experience.
Okay, thank you so much. Now we'll have a representative from Negas Med. We were to have a representative from the Israeli embassy, but they were not able to make it. So we'll have Stephen Kiragu just giving us a short presentation on their company, and then we'll go on to just do the closing remarks.
Thank you very much, Dr. Marco. Let me try and share my screen. I hope my screen is visible on your side.
We can see and we can hear. Go ahead.
Thank you very much. Now, my name is Stephen Kirago. I am from Negasmed. I manage the marketing of the medical surgical devices and also now the ophthalmology line that we have brought on board. Now, Negasmed is here as the link between our colleagues in Israel, that is iOptimizer company, and the doctors, and by extension, the patients here. So we would say thank you very much, Professor Shlomo, for that presentation, and also to you, Ahi. We have really benefited. And I would also wish to acknowledge the presence of doctors from other countries in the region. We've seen doctors from Burundi, from Zimbabwe, from Uganda. Thank you very much for creating some time to be here with us. Now, you'll agree with me that whenever healthcare is concerned, the patient is at the center, and so is the HCP, and that is why we are really trying to improve the healthcare standards, the quality, and the accessibility, as you will see herein. So Negasmed was founded some 3 years ago, and with the aim of investing in improving the standards of healthcare, bringing in the innovative technology as the world becomes a global village and is connected through technology. We really envision to bring to the East African region and Africa at large what is more cost effective, what is more acceptable to both the healthcare providers, to the payers when it comes to insurance, be it the NHIF we really want to bring what is very innovative. So the gap that we really are trying to close, that is very much repeated over and over again in Africa, is that question of accessibility, and that is as far as technology and training is concerned, and also the cost to the government, to the insurance companies, and to the patients who mostly in our African region will pay out of pocket. Now, the solution will be in partnering with health facilities, with government, with the health insurance. And one of the things that we are planning, and especially as far as the class approach is concerned, we are in advanced talk between iOptima and also with the help of Dr. Marco, that yes, we can try and bring a wet lab first, and then we can have Ahi and his team coming, doing some hands-on training for some time, and that now can enable us to start doing the physical handling of the patient. Then also we will try, the question of cost, as Dr. Marco has asked, we have not yet come up with what we may say the final cost, but we really want to see after the wet lab, because we might say the cost here, but when the machine goes to a healthcare facility, there'll be a little bit of markups here and there, but that now we will be in a position to handle. But we really wish to bring a very flexible payment system, either for the acquisition of the machine or just for the sake of the disposables. So basically in Negasmed, we are trying to invest in technologies, as you've been shown here today, that would of course bring very good cure rates, would reduce the complexity of surgeries, and also reduce on the hospital stays. Now, we have partnered not only with iOptima in the past, we have other companies, and amazingly also from Israel, such as IVT Medical with the top closure. We have got MedCU, Senahil, Sion Medical, and it's in the region of ophthalmology, wound care, theater equipment, PPEs, and other diagnostic devices. In the ophthalmology, also from iOptima, we have got the product, Elipitia, that is also coming on board very soon. And as you've said, we are on the route of bringing first, for the sake of the wet lab, the class system. And we are also in the business of distribution of medical devices in Africa. Now, we would wish to express great gratitude, of course, to Professor Melamed and Ahi for finding time and delivering a talk. We've seen attendees from all over the East African and South African region. We have the Glaucoma Society, and especially to Dr. Marco. We came to you and you really helped us. Having been referred to you by Dr. Bore from the OSK, we really appreciate. We were to have the Israeli embassy, but they have also been a very good link between us and iOptima. And of course, we cannot forget to thank our host, Coexa. So that is it from us. And with us here, we have got, we've got somebody called David Duke, who is the Chief Operating Manager for Negasmed. And we are also here with one of the founding directors of Negasmed, Dr. Austin Omune. And if there is any question that we can handle, we would very much appreciate. And the floor, I hand it over back to you, Dr. Marco.
Okay, thank you so much, Stephen, for your presentation. I think what is in everyone's mind right now is how much is the equipment, because you know, if we are to even think of purchasing it, we need to budget, yeah. That's at the top of everyone's mind right now. Can we have an estimate? So somebody has asked actually, is it in, what's the price range? Is it in thousands, millions, tens of millions? You are evading the question. You know, Kenyans are very direct, Stephen. You can't be asked a question and then unaenda, and then, okay, then you go like this and like that.
Okay. Thank you very much. We were doing a rough estimate and we thought we are working on models where maybe the machine would cost about 5 to 6 million. That is why we don't want to sound scary right now, because we are still in talks with iOptima, trying to deliver what could be most accessible to the patient, because we are thinking of either maybe having the machine and then we sell to the health institutions and to doctors some of the disposables, the surgical cards. So the machine itself would go to a tune of 6 million Kenya shillings, but that is not quite conclusive. So by the time, yes.
Sorry,
yes.
this is Yaron. Hello, everybody. My name is Yaron Sfadia. I'm the Director of Business Development at iOptima. I just want to mention there was a question raised regarding the cost in Europe. So I can say that in every country where we operate, whether it is in Asia, Europe, South America, and soon in Africa, the price is very competitive to the local market. It allows not only for the hospital to purchase this, but if it's regarding depending on the payment system at each country, reimbursement or co-pay or self-pay by the patient, it is very competitive. It allows the hospitals, the doctors also to benefit from it as well. So as Nagusmet just mentioned, we are still working on the details, but the idea is to provide a price that will be very competitive and very adventurous to your clinic, your hospital, your work. In addition to that, we will also allow for a number of models, as mentioned, whether it is to purchase the system as CapEx, capital expense, or to use a pay per procedure like disposable, that is also an option. And we also have, as mentioned, the blepharoplasty option to do with the system. So that's another model if someone would like to do glaucoma and blepharoplasty. So we're going to be very flexible. We're going to be very competitive. And Nagusmed will get back to each of anyone here who would like to get a concrete proposal very, very soon.
Okay,
thank you very much, Sharon, for coming to my rescue. And Dr. Marco, I know in this we will have a discussion later. We had proposed that we can use the University of Nairobi as a center for the wet lab because it would be very good. And we hope now, because our countries are opening up, we are opening up our country next week. We will plan the earliest visit possible with Yaron and his team to just come set up the machine the soonest possible, and then we can start with first the training, because yes, as you've said, we are going on. Back to you, Dr. Marco.
Thank you so much, Stephen. Honestly, when you come, we'll have to practice social distancing.
Most definitely.
Now, I think I'll just hand over back to the OSK team because I think we've run out of time. So I just want to comment something here by Dr. Karaoke. She has said your artwork in Israel is impressive because it's African. So Aki and your team, well done. So Dr. Bore from the Ophthalmology Society of Kenya, you can take over and just, if you have any announcements and closing remarks, go ahead. Vera, please unmute Dr. Bore if she's muted.
I think Dr. Bore has already left the meeting.
Korir should take over.
Okay.
For her team, just to close the meeting.
Yes. Dr. Korir, go ahead.
All right. Thank you very much. It was a really, really wonderful session. Let me just thank you, Israelite team, Optima, Dr. Marco. I think the sessions have been very wonderful. From OSK, we do not have much announcements today. We'll communicate next. Thank you very much.
Okay, thank you. I think we are free to leave the meeting. And if you have any questions, maybe Vera can share the email of Negas Med. If you have 6 million to spend, you can call Vera. She can give you their contact. But thank you and see you guys. I think next week we are having our glaucoma sessions. Thank you and bye-bye.